our EDIC Part 1 aspirants, and the speaker of today is Dr. Ashutosh Kumarkar. He is the head of department in Kailash Deepak Hospital, Delhi. His area of interest are in mechanical ventilation, hemodynamic monitoring, renal replacement therapy, and nutrition. And our today's topic is about acute coronary care. Sir, you may proceed.
Good evening, everyone. So today, a very important topic for EDIC Part 1 is acute coronary care. So 46-year-old man with atrial fibrillation, hypertension, hyperlipidemia, and diabetes is admitted with unstable angina. He undergoes coronary angiography, which demonstrated 90% stenosis of mid-left circumflex in a left dominant system. A single drug-eluting stent is deployed with an excellent angiographic result, and the patient is given aspirin and ticagrelor. The patient is admitted to cardiac services and shortly after arriving to the floor reports new onset chest pain. A 12-lead ECG is performed. ECG is in front of you. Can anybody tell me what is in this ECG? Inferior MI. Okay.
Inferior plus posterior wall MI.
Inferior plus posterior wall MI. Okay. So, which of the following is the next best step in the management? Intravenous nitroglycerin, observation, present repeat coronary angiography, transthoracic echocardiogram. What is your answer? Somebody is saying C, somebody is saying A. So answer is C. Basically, it's a case of stent thrombosis. So this is inferior posterior apical ST segment elevation, MI STEMI, in context of recently deployed stent. Stent thrombosis is an uncommon but serious complication, and it is less than 10% of cardiac death following stent replacement. Most cases occur within first 30 days of the stent placement, and it is independent of the stent type, either bare metal stents or drug-eluting stent. It doesn't make a difference. Basically, stent thrombosis can occur in any type of stent. So presentation is again the same: chest pain and ST elevation. Treatment: urgent coronary angiography with repeat revascularization. Most common cause for stent thrombosis is the drug discontinuation. Other risk factors like diabetes, side branch stenting, greater stent length, suboptimal stent apposition. But most common is the drug discontinuation, especially P2Y12 like clopidogrel or any other drug blood thinner which is given. Basically, when we place a stent, we use double antiplatelet agent, dual antiplatelet agent. Okay, so if you stop those medications, then this complication can occur. And the cumulative rate of stent thrombosis is 2% and 2 year, and similar for both bare metal stent and drug-eluting stent. So very high index of suspicion is the key for successful recognition and management. Second question. A 55-year-old male with known coronary artery disease with prior percutaneous coronary intervention of right coronary artery, 2 years prior to presentation, hyperlipidemia and hypertension, present to the emergency department with 2 days of exertional chest pain, with culminated in acute onset of stabbing substernal chest pain radiating to left shoulder. Temperature 36.3, BP is 200/89, heart rate 81, respiratory rate 18, saturation 93%. For a cardiac troponin T that is undetectable, means negative trop T. 12-lead ECG showing normal sinus rhythm, Q wave inferior leads, and non-specific ST segment changes. Plain film chest X-ray is obtained. Which of the following is most appropriate next step in the management? Angiography, CECT, pericardiocentesis, or transesophageal echocardiography? Somebody is saying C. Okay, so what is your diagnosis?
So, sir, can you
Pericardial
refer to
effusion.
Sorry?
The options? Can
Options.
you? Oh,
Option A is coronary angiography, CCT of the chest, pericardiocentesis, transesophageal echocardiography.
I think the answer is A. It's non-STEMI.
Okay. So answer is B, because this is a case of acute aortic dissection. You should see this thing: acute onset of stabbing substernal chest pain radiating to left shoulder. This is very important history. Chest pain, which acute onset of stabbing substernal chest pain radiating to left shoulder. Whenever this type of line is there, pain going towards back side or stabbing type of pain, it means you should think about the aortic dissection. So this is a case of aortic dissection because known risk factors for aortic male sex, history of hypertension, advanced age, connective tissue disorders. So more than 90% of patients with type A dissection report chest pain, while only 47% of patients with a type A dissection report back pain. So high index of suspicion should be there. And on examination, you can find also upper extremity pulse deficit or BP differential. So the bilateral blood pressure should be measured. In imaging, you can do CT angiography, MR angiography, transesophageal echocardiography, and aortography. So this is the common complications of aortic dissection. So you can see this acute MI 3%, aortic insufficiency 32%, rupture into pericardium, stroke 5%, paraplegia, renal ischemia, mesenteric ischemia, lower extremity ischemia. These are the common complications of the aortic dissection. And presentation, they always give some lines like stabbing chest pain or pain radiating to the back. This should be there. Then question number 3, a 66-year-old male with hypertension and hyperlipidemia presents with substernal chest pain. His presenting ECG demonstrates inferior ST elevation with reciprocal changes in high lateral leads. Emergent coronary angiography is pursued with percutaneous coronary intervention undertaken on a subtotally occluded right coronary artery. Aspirin, ticagrelor, metoprolol, and atorvastatin are initiated. He is admitted to ICU for post-intervention monitoring after repeat ECG showing resolution of previous ST segment elevation. 12 hours later, the patient develops subacute significant shortness of breath following medication administration. Patient oxygen saturation is 99% on room air. His physical examination is unremarkable. Repeat ECG unchanged from post-intervention. Contrast CT of the chest is negative for pulmonary embolism, which one of his medication is a potential culprit of dyspnea symptoms. Options are aspirin, metoprolol, ticagrelor, atorvastatin.
Ticagrelor.
Somebody is saying C, somebody is saying B. So yes, please. So answer is ticagrelor. Because it's a reversible direct acting oral antagonist of the adenosine diphosphate receptor P2Y12 is an active drug and provide more consistent P2Y12 inhibition than prodrug clopidogrel. So dose related dyspnea is associated with ticagrelor, or it has been seen that as many as 14% of the patient initiated on ticagrelor experience dose dependent dyspnea, which is described as sudden and unexpected air hunger or unsatisfied inspiration. So this is very important to know that ticagrelor is associated with dose-related dyspnea, dose-dependent dyspnea. Okay, so just remember this point. Now, a 65-year-old female with hypertension and hyperlipidemia develops substernal chest pressure with dyspnea. Physical exam is notable for the following: blood pressure 126/62, pulse is 76 beats per minute, saturation 97% on 4-liter nasal cannula. General sitting up with increased work of breathing, heart, regular rate and rhythm, grade 3 or 4 or grade 3, say 3/6, hollow systolic murmur is heard. at the cardiac apex, which is non-displaced on chest palpation. Lung posterior diffuse crackles, abdomen soft, non-tender, non-distended, extremities warm without edema, 12-lead ECG following. So options are, what is the most likely mechanism of this patient dyspnea? Pulmonary embolism, MR, LV systolic dysfunction, tamponade. Any guesses?
B. It's mitral regurg, acute mitral regurg.
Mitral regurgitation. Okay. So answer is B. Mitral regurgitation. So basically, you need not to see the ECG in this MCQ, because the murmur is important lead or important clue to solve this question. So holosystolic murmur at left sternal border with pulmonary edema is a important thing which tells about the acute MR, mitral regurgitation. So patient present with a clinical syndrome suggestive of acute coronary syndrome. ECG is showing ST segment depression in right precordial lead V1 to V3 with prominent R waves. So you can see this is the ST segment depression in V1, V2 and V3 with prominent R wave. Okay. So this tells us about the posterior MI. Attention should be paid to increased risk of papillary muscle ischemia leading to acute MR, and holosystolic murmur left sternal border pulmonary edema that corroborate the diagnosis. However, a murmur may not be heard in up to 50% of cases, but in this question it is given that murmur is there. That's why the diagnosis is very clear. This is MR, mitral regurgitation. Then question number 5, a 96-year-old female is admitted to ICU for closer hemodynamic monitoring following uncomplicated deployment of a drug-eluting stent to the first obtuse marginal via left radial artery. In the context of presentation consistent with an ST elevation MI, 4 hours post-procedure, the patient developed acute hypotension necessitating the vasopressor support. 12-lead ECG is performed. Options are, compared to our post-inter ST segment elevation lead 2, 3, AVF, P5, V6, but are less prominent, otherwise no significant changes. Assessment of left radial access site is unrevealing. What is the best next step in management? Repeat diagnostic coronary angiography, urgent surface echocardiogram, CT of abdomen, right heart catheterization.
Urgent echo.
Echo. What are you thinking?
Yes. It's maybe hypotension due to cardiac tamponade due to complication of cardiac cath.
Yes, absolutely right. Complication of diagnostic coronary angiography and percutaneous coronary intervention that can cause hypotension include coronary perforation leading to cardiac tamponade, access site complication leading to bleeding, or intracoronary artery complication leading to left ventricular dysfunction and impaired cardiac output. So they have already told us that bleeding site, there is no bleeding at the site of coronary angiography. So that is not, that is ruled out. So in the absence of access site compromise, transthoracic echo should be considered for evaluation of pericardial effusion and mechanical complication of MI. Coronary artery perforation is a rare complication occurring in less than 1% of treated lesions. Perforation can be caused by a wire exiting a vessel or by compromising the vessel wall by a balloon. Most cases of perforation are identified intra-procedurally, but upward of 13% of cardiac tamponade incidents can be delayed and occur within 24 hours after departure from cath lab. So it's very important. This is a rare but significant complication of the coronary angiography, coronary artery perforation. So incidence is less than 1%, but it can occur or it can detected during the procedure or maybe within 24 after the procedure. So very high index of suspicion, and to confirm this, you need to do echocardiography. Okay. Next, a 57-year-old male with a history of hyperlipidemia is admitted to ICU with hypotension necessitating vasopressor support. He had been in usual state of health, but in preceding 24 hours, he developed progressively worsening dyspnea, culminating in respiratory failure and necessitating intubation. His admission ECG is shown here. He presenting 𝒕𝒓𝒆 is 2.52. Shortly after admission, patient is witnessed to have repeated episodes of self-terminating VT, longest of which last up to 45 seconds. An echo is performed and demonstrates severe biventricular dysfunction with an estimated left ventricular ejection fraction of 12%. Which of the following would be the most appropriate next step in management? Urgent coronary angiography with the intent to revascularize, insertion of percutaneous LVAD, insertion of IABP, cardiac biomarker panel.
A.
Urgent coronary angiography with intent to revascularize. Yes. Okay. So answer is A, because patient is showing that rapidly decompensating heart failure leading to cardiogenic shock. And his 12-lead ECG showing Q wave consistent with old MI, anteroseptal interval infarction, suggesting that ischemia may be related causally to the biventricular dysfunction. So while consideration of ventricular support device in this case is important, a univentricular support device such as IABP or percutaneous LVAD would likely be inadequate in presence of biventricular failure. So there is a minimal evidence in favor of IABP or PVAD in cardiogenic shock. Ventricular arrhythmia are likely a consequence of acute decompensation on the background of severe biventricular cardiomyopathy. So immediate diagnostic angiography with intent to perform revascularization is indicated in patient with non-ST elevation MI who have refractory angina or hemodynamic or electrical instability. Okay, so options B, C ruled out because problem is the biventricular failure. So it will not help because it will help only for the on the left side. So in this situation, you need to do for urgent coronary angiography with the intent to revascularize. That is the best possible treatment in this situation. Next,
Hello?
Sorry.
Hello? Congratulations.
Sorry. So next question is 88-year-old male with complex coronary disease that includes prior 3-vessel coronary artery bypass grafting and prior complete heart block necessitating dual chamber permanent pacemaker implantation. Please, Dr. Sanjay, please mute yourself. An 88-year-old male with complex coronary disease that include prior 3-vessel coronary artery bypass grafting and prior complete heart block necessitating dual chamber permanent pacemaker implantation, present with substernal chest pain identical in character to his past angina. His present ECG is this. And 𝒕𝒓 is 0.54. Which of the following next best step in management? Emergent coronary angiography with intent to revascularize, urgent coronary angiography with the intent to revascularize, non-invasive risk stratification on IV nitroglycerin.
A. It's inferior MI. It's need to, yes.
A means emergent
Yes.
coronary
Yes.
angiography. Yes. So answer is early diagnosis of STEMI remains key in determining management. Early diagnosis leads to earlier reperfusion, with ultimately improves mortality. Diagnosis of STEMI necessitate the presence of new ST elevation, at least 2 contagious leads. Diagnosis of MI and myocardial ischemia and infarction in the presence of conduction disturbance is more challenging because it might be LVB or RBB. So in patient with LVB, ST segment elevation more than 1 mm concordant with QRS complex in any lead may be an indicator of acute myocardial ischemia.